Hello, everyone. I'm Dr. Carmen Pugliafito. Welcome to Retina Synthesis. Today, we're pleased to have with us Dr. Sumit Sharma of the Cleveland Clinic Cole Eye Institute, who was the lead investigator on the Dovetail study, which looked at IL-6 inhibition in the treatment of macular edema associated with uveitis. Dr. Sharma, welcome to Retina Synthesis.
Thank you for having me. It's a pleasure to be here.
IL-6 or interleukin-6 is an important inflammatory cytokine in the eye. Can you tell us a little bit about this molecule?
Yeah, so it's a new pathway, right? So we've had anti-VEGF for a very long time, but IL-6 is newer in terms of a therapeutic target, and it does a number of things. So dysregulated IL-6 secretion leads to both inflammatory cells recruited to the eye and infiltration into the surrounding tissues. You get breakdown of the blood-retinal barrier, which leads to vascular leakage and the formation of macular edema. So IL-6 has really been thought of as a causative agent of macular edema in not just uveitis, but other ocular diseases, including diabetes and vein occlusion. And it's a possible other pathway that we can target other than VEGF.
So tell us a little bit about the Dovetail study.
So Dovetail is a phase 1 dose ranging study and it's a little complicated because it's got 4 parts. Parts 1, 2, and 3 were in DME, and those have not been reported yet. And I reported the results of the part 4, which was specifically in the uveitic macular edema subset, where patients got one of 3 different doses, either 0.25 milligrams, 1 milligram, or 2.5 milligrams given at baseline, month 1, and month 2. And then they were followed in an off-treatment observation period up to week 36 to see how they do afterwards. And so there was about 12 subjects in each of the 3 cohorts in part 4. All of them had underlying uveitis, and they could have been on other treatments already, but they had to have they had to have both stable treatments, so whatever their immunosuppression was had to be stable. They had to have active macular edema despite that, and then they were treated, and we saw how they did over time.
So they were treated with a single intravitreal injection?
No, 3. So it was at baseline, month 1, and then month 2. So day 1, week 4, and week 8. And it was one of 3 doses, either 0.25 milligrams, 1 milligram, or 2.5 milligrams.
And so when did you observe them? At 6 months or a year?
So the primary outcome measure for this was at week 12. So we were just looking to see, so since it was a phase 1, the primary objective was safety and tolerability. And the secondary objective was efficacy, pharmacokinetics, and anti-drug antibody formation.
So the percent 3-line gainers, as I read the study, was pretty impressive.
Yeah, it was fantastic. About a third of the patients gained 3 lines. And what was even more impressive was there was a smaller portion that was even capable of gaining 3 lines, because a large portion of the patients already had more than 70 letters at baseline.
Right. That's always a challenge. So what were these patients suppressed with initially in general?
So it was a mix. Some patients didn't have any other treatment, and some patients were on either an antimetabolite such as methotrexate or Cellcept, or other immunosuppressives. They could not be on any systemic anti-IL-6 or systemic anti-IL-17, but they were allowed to be on other immunosuppressive medications depending on what their underlying uveitis etiology was. About half were getting other treatments and half were not.
So just for asking you to speculate, do you think IL-6 inhibition works better than corticosteroids?
So I mean, we didn't compare directly, number 1. Number 2, corticosteroids lead to pan suppression, right? So you're not just blocking one pathway, you're blocking multiple different inflammatory pathways. So I can't imagine it works as well. However, I think the side effect profile here was much better in that there was no incidence of IOP rise, no incidence of cataract formation, which are the 2 things that we worry about the most with corticosteroids.
So what's the next step with this antibody?
Yeah, so for uveitis, they've already moved into phase 3 studies. So there's 2 actively enrolling phase 3 studies. for uveitis. And in DME, they have moved on to phase 2 studies. So all of those are actively enrolling. And, there's a number of therapies, as you very well know, that have done looked very promising in early phase studies and then not panned out. But I think the overall safety and tolerability was so good for the uveitis subset that they moved right to phase 3.
What's the phase 3 design like?
Phase 3 design is similar in that patients will get 3 loading doses at baseline, and then they're followed out to a year with PRN treatments after the first 3 loading doses. So if they have recurrence of edema, they can be treated again, but if they don't, they're just monitored.
Mm-hmm. And what are the diabetic macular edema studies look like? When will they be? When will the phase 1 results be reported?
Once the phase 1 diabetes cohort is complete, the uveitis cohort was complete a little earlier, but the diabetes one wasn't yet. So I'm not certain when Roche is planning to report that, but hopefully soon. The phase 2 studies, they're a little different for DME in that there's either combination therapy with ranibizumab or monotherapy. And there's 2 different phase 2s. One is looking at combo therapy, one is looking at monotherapy.
So talking a little bit about biology, is IL-6 blockade more relevant than anti-VEGF blockade in treating macular edema?
I think it depends on the underlying disease etiology, right? So in uveitis, I think it is. In uveitis, there's not a ton of VEGF that's being produced, except for in occlusive retinal vasculitis cases or other cases where you're having loss of blood flow. In diabetes, I think VEGF plays a very predominant role, but we know that about a third of those patients with diabetes don't respond much, if at all, to anti-VEGF, and there's probably other cytokines at play, and those are the patients where IL-6 may make a lot of sense. What we really would need is baseline cytokine profiling on those patients to know, hey, this is which ones have a high IL-6 level versus high anti-VEGF or high VEGF level, where anti-VEGF would be more likely to work. We don't do that at baseline right now, and we don't really have a relevant assay that we can use commercially for that either. So it would be more, you treat them with anti-VEGF, you don't get a response, and then it makes sense. But in uveitis, I think anti-IL-6 makes a ton of sense because IL-6 drives a lot of macular edema formation in uveitis.
So Kodiak is looking at a bispecific antibody that blocks both anti-VEGF and IL-6 for treating, I think, choroidal neovascularization. Is that right?
Mm-hmm. They are, and also they think they're considering it in DME and in uveitis. So they're looking at it in multiple different venues. So we'll see what happens with that.
Do you think IL-6 is a relevant molecule in neovascular AMD?
Less likely, just based on the biology there is a little bit different in that the IL-6 levels that aren't as high generally in neovascular AMD than DME or uveitis, but it's a possibility they could have a small additive effect.
Yeah. Well, great having you on Retina Synthesis. This is exciting, and I think IL-6 blockade is going to be an important mechanism going forward.
Yeah, I do too. I think the safety profile is what was most exciting on the uveitis side, in that none of the patients had any issues with IOP or with cataract, and the results were very, very good. So it's very exciting to see what will happen.
Thank you very much.
Thanks for having me.